Pink in the sink this morning, a trace of blood when you brushed. Gone before you thought about it. That blood came from a barrier 1 cell thick separating 700 bacterial species in your mouth from your bloodstream. The barrier just told you it is open. The bacteria that crossed through it have been found inside the arterial plaques that cause heart attacks, identified by DNA, lodged at the exact branch points where plaque ruptures. They arrive through your gums. Their toxic enzymes have been correlated with the tau tangles in Alzheimer's brain tissue. They have been found in colorectal tumors. They did not arrive through the stomach or the lungs, they arrived through inflamed gum tissue, through a pathway that opens every time the biofilm between your teeth is left undisturbed for 48 hours. Treating the gum disease that opens this border improved arterial function in a New England Journal of Medicine trial by an amount comparable to starting a statin. The intervention that closes the border is a piece of string. It costs less than a penny per use, takes 2 minutes, and works because it physically demolishes the bacterial fortress keeping the border open. Border physics first. The barrier between your mouth bacteria and your bloodstream can be measured in electrical resistance, and it drops measurably when inflammation loosens the seals. Gingival sulcus, the shallow groove between the tooth surface and the gum tissue, is sealed by epithelial cells, connected through tight junction proteins, claudins, occludins, zo1. These proteins form a physical seal between adjacent cells that can be quantified through transepithelial electrical resistance, TR. Healthy gingival epithelium maintains high TR. The junctions are tight. Bacteria and their products cannot cross from the oral cavity into the capillary network beneath. Inflammation changes the physics. When bacterial biofilm matures against the gum tissue for 48 hours or longer, the pathogenic species produce toxins that trigger an inflammatory response. Inflammatory mediators, histamine, bradykinin, prostaglandins, act directly on the tight junction proteins. The junctions loosen, TER drops measurably. The paracellular spaces between epithelial cells widen from effectively zero to gaps large enough for bacterial cells to pass through. Simultaneously, inflammation dilates the capillaries in the gum tissue, increasing blood flow, which is why inflamed gums appear red and bleed on contact. Dilated capillaries with increased permeability sit directly beneath an epithelial barrier whose tight junctions have loosened. Bacteria now have a path through the widened paracellular gaps, across the basement membrane, and directly into dilated permeable capillaries that carry them into the systemic circulation within seconds. The pink in the sink is not cosmetic. It is the visible evidence of dilated capillaries beneath a barrier whose structural integrity has failed under inflammatory load. The immune battle at the gum line is continuous and measurable. The gingival sulcus contains gingival crevicular fluid, a serum, exudate that flows from the capillaries through the junctional epithelium into the sulcus at a rate that increases with inflammation. This fluid carries neutrophils, immunoglobulins, and complement proteins into the sulcus to combat the bacterial biofilm. In health, the flow is minimal and the bacterial challenge is contained. In gingivitis, the flow increases as the inflammatory response escalates, more immune cells recruited, more inflammatory mediators produced, more tight junction damage inflicted by the immune response that is trying to contain the infection. The immune system's attempt to fight the bacteria is partly responsible for the barrier damage that lets the bacteria cross. The inflammation is both the defense and the vulnerability. The neutrophils that arrive to fight the biofilm produce reactive oxygen species and MMPs that damage the epithelial tight junctions as collateral damage from the immune response itself. Bacteremia occurred in 23% of subjects after toothbrushing and 30% after flossing, as Lockhart and colleagues documented in Circulation in subjects with pre-existing gingivitis, where the barrier was already compromised. In subjects with healthy, intact tight junctions, the rates were dramatically lower. Destination next oral bacteria in the bloodstream do not distribute randomly, and the locations they choose are determined by fluid dynamics. Once in the bloodstream, oral bacteria lodge at specific locations, the branch point geometry the plaque discussion described, where low oscillatory shear stress damages the endothelium and permits both cholesterol entry and bacterial adhesion. In straight arterial segments, high laminar shear stress keeps the endothelial surface clean, bacteria flowing through are swept past by the high velocity flow and cannot adhere. At bifurcations where the carotid divides, where coronary arteries curve, where the aorta branch's flow becomes disturbed, shear stress drops, and the damaged endothelium that emits cholesterol also permits bacterial attachment. Porphyromonas gingivalis, the keystone pathogen of chronic periodontal disease, produces adhescent proteins called fimbriae that bind to receptors on damaged endothelial cells. In high shear laminar segments, flow velocity exceeds the binding force, the bacteria cannot stick. At the low shear branch points, flow velocity drops below the adhesion threshold, the bacteria adhere, penetrate the endothelium, and embed within the existing plaque. P. gingivalis DNA was detected in approximately 42% of atherosclerotic plaque specimens, as Harasthi and colleagues reported in the Journal of Periodontology. The bacteria were not on the surface, they were inside the plaque tissue, at the branch points where disturbed flow created the conditions for both plaque formation and bacterial lodging. The geometry that builds the plaque is the geometry that catches the bacteria. One physical principle, low shear stress, at arterial bifurcations, selecting the location for both processes simultaneously. Bacteria are not passive passengers. Their presence within the plaque promotes local inflammation through interleukin-6, tumor necrosis factor alpha, and matrix metalloproteinases, the cap-degrading enzymes established in prior discussions, now produced inside the plaque by a bacterial source. The oral bacteria from your gum line are actively making your arterial plaques less stable, more likely to rupture, more likely to produce the clot that causes a heart attack or stroke. The bacteria that entered through a one-cell thick barrier in your mouth are now thinning a 65 micrometer thick cap in your coronary artery through MMP-driven cap degradation, driven here by a bacterial source operating from the gum line. And then the fortress, because the bacterial community between your teeth is not a passive film but an engineered structure that antibiotics cannot penetrate and your immune system cannot breach. A toothbrush reaches approximately 60% of the tooth surface, the buccal, lingual, and occlusal surfaces. The interproximal surfaces between adjacent teeth, where teeth contact each other, are inaccessible to bristles. These surfaces are where the biofilm is thickest, where the gingival sulcus is deepest, and where gingivitis most commonly originates. 48-hour timeline is specific and measurable. Hour 0 after mechanical cleaning, the tooth surface is bare enamel coated within minutes by a salivary glycoprotein pellicle. Within 2 to 4 hours, pioneer bacteria Streptococcus gordoni, Streptococcus sanguinis, Actinomyces, Naislandii adhere to the pellicle through specific receptor adhesion interactions. These pioneers are not pathogenic, they are the scaffolding. The bacterial community assembling between your teeth follows this exact sequence, and the hours since your last flossing determine which stage it has reached. Within 12 to 24 hours, secondary colonizers attach to the pioneers through coaggregation, physical binding between complementary surface molecules on different bacterial species, as specifically structured as a lock and key. Fusobacterium nucleatum serves as the bridge organism. Its surface receptors bind to both early and late colonizers, connecting the benign pioneer community to the pathogenic species that arrive last. Within 24 to 48 hours, the late colonizers arrive. P. gingivalis, Tannerella forsythia, Treponema denticola, the red complex that periodontal microbiology identifies as the primary pathogens of chronic periodontitis. These species produce the virulence factors gingipains, lipopolysaccharide, leukotoxins that trigger the inflammatory cascade, degrading the tight junctions. The community simultaneously constructs a polysaccharide matrix, a physical shield that reduces antibiotic penetration by 1,000-fold, blocks neutrophil access, and resists antimicrobial mouthwash. This matrix is the fortress wall. Only intervention that destroys the fortress is mechanical disruption, physically breaking the matrix apart. Mouthwash cannot do it. Antibiotics at achievable oral concentrations cannot do it. The toothbrush cannot reach the interproximal surface to do it. Floss physically contacts the fortress wall, shears it from the tooth surface, and collapses the community. Biofilm clock resets to 0. The breath odor that returns predictably between flossing sessions is the volatile sulfur compounds hydrogen sulfide, methylmercaptan produced by the anaerobic bacteria in the subgingival biofilm as metabolic waste products. The odor is a direct chemical indicator of biofilm maturity. The stronger the odor, the more mature the community, the closer it is to the 48-hour pathogenic threshold. Fresh breath after flossing is the measurable absence of the metabolic products the pathogenic community produces. The 48-hour countdown to pathogenic maturity starts over. If you brush twice daily and never floss, you are maintaining 60% of your tooth surfaces while allowing the biofilm on the remaining 40%, the 40% most likely to produce gingivitis and bacteremia, to build an antibiotic-resistant, immune-evasive fortress indefinitely. The floss demolishes the fortress before the cascade begins. You now know the border, the branch points where the bacteria lodge, and the fortress that keeps the border open. The question changes from the physics of the pathway to whether closing it reverses the arterial damage. Patients with severe periodontitis received intensive periodontal treatment, scaling, root planing, extraction of hopeless teeth, comprehensive biofilm removal. 6 months later, endothelial function was measured by flow-mediated dilation. Endothelial function improved significantly by a magnitude comparable to adding a statin, as Tonetti and colleagues demonstrated in a New England Journal of Medicine trial in 2007. Treating gum disease improved artery function to a degree comparable to a pharmaceutical intervention designed specifically for arteries. The mechanism, removing the chronic source of bacteremia and systemic inflammation, reduced inflammatory markers, high-sensitivity C-reactive protein, interleukin-6, which reduced endothelial inflammation, restored nitric oxide production, and improved vasodilation. Age compounds every element of the oral systemic cascade. Gingival tissue thins with age. The epithelial barrier that separates bacteria from blood becomes physically thinner, with fewer cell layers and weaker tight junctions at baseline. Salivary flow decreases. Saliva contains antimicrobial enzymes, lysozyme, lactoferrin, secretory IgA, that suppress bacterial overgrowth, and the reduced flow removes a chemical defense the mouth depends on. Immune surveillance in the gingival tissue becomes less efficient. The neutrophils that patrol the sulcus respond more slowly and kill bacteria less effectively. The biofilm that a 25-year-old's immune system contained at a subclinical level becomes clinically significant at 60 because every layer of defense, physical barrier, chemical defense, immune response has weakened. The 48-hour biofilm that was manageable at 30 is pathogenic at 60 through no change in bacterial behavior, only a change in the defenses arrayed against it. Medication-induced dry mouth, a side effect of over 500 common medications, including antihypertensives, antidepressants, antihistamines, and diuretics, accelerates the cascade by further reducing salivary flow. If you take medication that makes your mouth feel dry, the antimicrobial defense in your saliva is operating at reduced capacity, and the biofilm is maturing faster against weaker chemical opposition. The flossing becomes more critical, not less, precisely because the pharmaceutical intervention you need for one condition is creating the oral environment that opens the bacteremia pathway. Now the second border, because the blood-brain barrier fails through identical tight junction physics as the first, but on a different timeline and with different consequences. Brain is protected by the tightest epithelial barrier in the body, endothelial cells, in the cerebral vasculature, connected by tight junctions with TER values 50 to 100 times higher than peripheral capillaries. The barrier is so selective that most molecules in the bloodstream cannot cross it. Most bacteria cannot cross it. But the tight junction proteins that maintain this seal, claudins and occludins, identical to those sealing the gingival epithelium, degrade with age. Decades of hypertension exert mechanical stress on the cerebral endothelium. Chronic systemic inflammation, including the inflammation fed by periodontal disease, degrades tight junction proteins through MMP enzymes. By 60, the blood-brain barrier is measurably more permeable than it was at 30, loosened enough that bacteria which could not cross at 30 can cross at 60. Gingivalis gingipain enzymes were detected in postmortem brain tissue, as Domini and colleagues reported in Science Advances in 2019, at levels correlating with tau and ubiquitin pathology. Gingipain enzymes degrade tau protein, producing the tau tangles that are a hallmark of Alzheimer's pathology. The bacterium also activates microglial inflammatory responses that produce the chronic neuroinflammation associated with neurodegeneration. Fusobacterium nucleatum, the bridge organism that connects pioneer and pathogenic species in the oral biofilm, has been found in colorectal tumor tissue. F. nucleatum was significantly enriched in colorectal carcinoma samples, as Castellarin and colleagues reported in Genome Research, compared to adjacent normal tissue. The bacterium promotes tumor growth through direct activation of beta-catenin signaling in epithelial cells and through suppression of the anti-tumor immune response, specifically inhibiting NK cell and T cell activity within the tumor microenvironment. Infective endocarditis infection of the heart valves is directly caused by oral bacteria entering the bloodstream through the gingival border in patients with pre-existing valve abnormalities. The bacteria adhere to damaged or prosthetic valve surfaces, form vegetations, and destroy the valve tissue. This connection is so well established that antibiotic prophylaxis before dental procedures is standard medical practice for patients with specific cardiac conditions. The border between the mouth and the bloodstream is not theoretical. Cardiology has been managing its consequences for decades in the highest risk patients. Prosthetic joint infection, bacterial colonization of artificial hip or knee replacements can originate from oral bacteremia through an identical pathway. Bacteria entering the bloodstream through inflamed gums can seed the surface of prosthetic joints, where the immune system has limited reach because the metal and polymer surfaces cannot mount an immune response. For anyone who has undergone joint replacement, and joint replacement is among the most common surgeries in the 60-plus demographic, the oral bacteremia pathway represents a route through which the implant they depend on for mobility can become infected from a source they associate with their teeth, not their joints. Connection is the lower grade, chronic version of the same pathway, not acute valve infection but chronic inflammatory seeding of arterial plaques through daily low-level bacteremia that the border, when inflamed, permits continuously. Rheumatoid arthritis connects to the oral pathway through a mechanism distinct from the inflammatory cascade, P. gingivalis produces an enzyme called peptidylarginine deaminase that citrulinates human proteins, converting arginine residues to citrulline. The immune system does not recognize citrulinated proteins as self and mounts an autoimmune response against them. Anti-citrulinated protein antibodies are the most specific diagnostic marker for rheumatoid arthritis, and their presence correlates with periodontal disease severity. The bacterium from the gum line is chemically modifying your own proteins in a way that triggers the immune system to attack your own joints. Undisrupted biofilm matures P. gingivalis. The border admits it to the bloodstream. The bacterium reaches joint tissue. Its enzyme citrulinates the local proteins, and the immune system responds to the modified proteins as foreign. For anyone managing rheumatoid arthritis or carrying the antibodies that predict its development, the oral biofilm is a potential upstream trigger operating through a protein modification pathway. No anti-inflammatory medication addresses at its source. Evidence for the Alzheimer's causal chain is preliminary, supported by correlation, animal models, and mechanistic plausibility, but not confirmed by prospective human intervention trials. The evidence for the arterial connection is confirmed by the New England Journal of Medicine trial. The distinction matters and should be held. But the direction of the evidence is consistent across every organ the blood reaches. Well, the systemic cascade, because chronic gingivitis feeds the same inflammatory pool that drives cardiovascular disease, and the connection tightens with age. Inflamed gum tissue produces inflammatory cytokines locally, while the bacteria crossing into the bloodstream trigger systemic immune responses. The combined local and systemic inflammation elevates the markers high sensitivity CRP, interleukin-6, tumor necrosis factor alpha, that predict cardiovascular events independently of cholesterol or blood pressure. If you have controlled your blood pressure, managed your cholesterol, maintained your weight, and exercise regularly but have untreated gingivitis, you are carrying a chronic inflammatory source that all your other health behaviors cannot address because they operate on different pathways. That additivity, a chronic inflammatory source operating beneath every other intervention, invisible on the lipid panel, absent from the blood pressure reading. Unaddressed by the exercise routine is why my 2 minutes before brushing shifted from routine to requirement once the Tonetti data arrived, not dental hygiene, but vascular maintenance performed at the bathroom sink. Smoking amplifies the oral systemic cascade at every step. Nicotine constricts the gingival blood vessels, reducing the visible bleeding that would otherwise alert you to the inflammation. Smokers often have advanced periodontitis with minimal bleeding because the vasoconstriction masks the warning sign. Simultaneously, smoking impairs neutrophil function, reduces salivary IgA levels, promotes anaerobic bacterial growth in the sulcus, and delays wound healing, accelerating biofilm maturation while suppressing every layer of defense. The combination of hidden inflammation and accelerated bacterial pathogenicity means smokers carry the highest periodontal disease burden while receiving the least visible warning from their gums. If you smoke and your gums do not bleed when you brush, the absence of bleeding is not reassurance. It is vasoconstriction, concealing the inflammation that is opening the border without the visible signal that would prompt you to act. Diabetes and periodontal disease operate in a bidirectional cycle that amplifies both conditions simultaneously. Elevated blood glucose impairs neutrophil function. The immune cells that should contain the oral bacterial infection become less effective at chemotaxis, phagocytosis, and intracellular killing. The periodontal infection worsens because the immune response is compromised. Simultaneously, the chronic inflammation from the worsening periodontal disease elevates systemic inflammatory markers that increase insulin resistance, making the diabetes harder to control. The periodontal infection feeds the diabetes that feeds the periodontal infection. For anyone managing type 2 diabetes, periodontal treatment is not separate from metabolic management, it is part of it. Reducing the chronic inflammatory load from the gum line improves the insulin sensitivity that the gum inflammation was degrading. That connection is why I floss before I brush every evening now for the border itself, because every night it stays open is a night I cannot take back. And then the protocol, because 2 minutes with a piece of string closes the border that connects your mouth to your arteries. Evening flossing is mechanistically optimal, disrupting the biofilm that accumulated during the day before the overnight period when salivary flow drops to its lowest level and the chemical defense against bacterial overgrowth is at its weakest. The bacteria in an undisrupted biofilm grow faster overnight because the salivary antimicrobials that slow their growth during waking hours are largely absent during sleep. Disrupting the biofilm before sleep resets the community to its pioneer stage at the moment when overnight growth conditions would otherwise accelerate its maturation toward the pathogenic 48-hour threshold. Floss once per day. Before brushing, the floss disrupts the interproximal biofilm, and the subsequent brushing clears the disrupted material. The specific floss type, waxed, unwaxed, tape, pick, matters less than the mechanical disruption. Any device that physically contacts the interproximal tooth surface and breaks the biofilm matrix is effective. Mechanical physics of flossing below the gum line deserves specific attention because the bacterial community producing the tight junction damage is not on the visible tooth surface, it is in the subgingival sulcus, the 1 to 3 mm deep groove between the tooth root and the gum tissue. Cleaning only the visible interproximal surface removes the cosmetically visible plaque, but leaves the subgingival pathogens undisturbed, the community most responsible for the inflammatory cascade that opens the border. The C-shaped technique wraps the floss around the tooth root and extends into the sulcus, disrupting the subgingival biofilm that the visible surface cleaning misses. Guide the floss between two teeth. Curve it around one tooth in a C-shape, slide it below the gum line 2 to 3 times. Curve around the adjacent tooth. Repeat. Water flossers, devices that direct a pressurized stream of water between the teeth, provide an alternative mechanical disruption pathway for anyone whose dexterity makes traditional flossing difficult. Arthritis in the hands, limited grip strength, dental work that catches traditional floss. These are common in the 55-plus demographic, and they are the primary reasons daily flossing stops. The water flosser disrupts the biofilm through hydraulic force rather than physical string contact. Studies comparing water flossers to string floss show comparable reductions in gingivitis and gingival bleeding. The mechanism differs, but the outcome biofilm disruption below the gum line is achieved through both methods. For anyone who has stopped flossing because their hands cannot manage the string, the water flosser provides the mechanical disruption the boarder requires through a delivery system the hands can operate. Approximately 2 minutes for a full mouth. The bleeding that occurs in the first week of flossing after a long absence is the gingivitis responding to the disruption. The inflammation that was maintaining the open bacteremia pathway is being addressed. The bleeding resolves within 7 to 14 days of daily flossing as the gingival inflammation subsides and the epithelial barrier restores its tight junctions. The tear rises, the border closes. Professional dental cleaning, scaling, and root planing performed by a dental hygienist addresses the calcified biofilm, calculus, that daily flossing cannot remove. When biofilm is left undisturbed long enough, the mineral content of saliva deposits calcium phosphate crystite into the matrix, hardening it into calculus, a mineralized bacterial fortress that no amount of flossing will remove, because the structure has converted from organic polymer to inorganic mineral. Calculus provides a permanently rough surface that the biofilm reattaches to more readily than smooth enamel, accelerating the 48-hour maturation cycle. Professional cleaning removes the calculus and returns the tooth surface to the smooth baseline, where daily flossing can maintain the 48-hour reset. The professional cleaning handles the years of accumulated mineral. The daily flossing handles the 48-hour cycle going forward. Both are necessary, neither alone is sufficient. If you have not flossed in years and start tonight, you are closing a border that has been open for years, a border through which oral pathogens have been entering your bloodstream, seeding arterial plaques at the branch points where disturbed flow catches them, and systemically elevating the inflammatory markers that drive cardiovascular disease. 2 minutes per day. The simplest vascular intervention nobody thinks of as vascular. The connection between your mouth and your arteries was published in the highest impact medical journal in the world. If your gums bleed when you floss for the first time in months, the bleeding should resolve within 7 to 14 days of daily flossing as the inflammation subsides, the tight junctions retighten, and the TR values recover. If the bleeding persists beyond 2 weeks of daily flossing, the inflammation may have progressed beyond gingivitis into periodontitis, attachment loss, bone resorption, pocket depths exceeding 3 millimeters, requiring professional treatment that flossing alone cannot resolve. A dental evaluation at that point addresses the structural damage the chronic infection has produced, and the Tonetti data demonstrates that treating the periodontitis produces the arterial improvement the ongoing infection was preventing. Intervention is in the drawer next to your toothbrush.